Welcome to PAH.TV Clinical Insights. This discussion is about recent advances in PAH incorporating the evidence and is moderated by Dr. Vallerie McLaughlin. Our panel discussants are Dr. Nick Kim, Dr. Harold Palevsky, Dr. Paul Forfia, and Dr. Sean Studer.
Hi, I'm Vallerie McLaughlin from the University of Michigan, and I'm really excited to be here today with some of my valued and esteemed colleagues to talk about some of the recent exciting news in pulmonary hypertension. 2014 and 15 are really thrilling years. New therapies, new trials, new trial designs, new treatment approaches. So we're going to talk about some of those issues today. Sean, you want to start telling us a little bit about Seraphin, macitentan?
Sure. So I think this has been an exciting last couple of years for us because we've moved really from an era where we were very focused on shorter-term trials to longer-term trials, and Seraphin was one of those examples. So it reflected what the World Symposium wanted, longer trials with more robust measures of endpoints. And so MASI was studied basically in patients to see if they could avoid some sort of worsening event, such as transplant, death, needing additional medication, prostacyclins, and the like. And it also involved more patients than we previously saw. So at 742 patients studied for median about 2 years, some is up to about 3.5 years, it gave us data for another treatment option that was stronger in terms of the study design from what we saw before. So we have an ability to look at things and talk to a patient about what's the chance you might reduce hospitalization and things like this versus trying to translate a 6-minute walk meeting.
Right, and also provide some longer-term safety data, which I think is really important to the patients. Nick?
Yeah, so RealCiguat was quite the news because it was the first time a drug got approved both for PAH, WHO Group 1, as well as CTEPH, WHO Group 4. And it was studied in a parallel complementary phase 3 trial. So PATENT 1 and CHEST 1 led to the approval of RealCiguat. It's an oral therapy. It's unlike PDE5 inhibitor in that it directly stimulates SGC to create cyclic GMP. And this was a 6-minute walk design study with both studies reaching positive endpoints that led to the approval. So for the first time, again, we have now a therapy for inoperable patients with CTEPH. For PAH, actually the study included half of the patients were actually on background therapy, most commonly ERA, and that also showed robust 6-minute walk improvement as well.
Yeah, it's really exciting to have something available for CTEPH patients. I know that's near and dear to your heart. And the excitement kept rolling on into 2014 and early in 2015. There are a couple of other really important and exciting trials that we can talk a little bit about. They haven't fully been published. But Paul, the AMBITION trial is a new treatment strategy. What do you think of that?
Well, this is a fascinating study. You know, this was the first study that addressed upfront combination therapy in patients with pulmonary arterial hypertension, as you know. We all have used combination therapy in one way or another for years. Typically as sequential add-on therapy, a patient is on an ERA and then we add a PDE5, or on a prostacyclin and we add a PDE5. But this was a trial where we tested whether patients with PAH could be treated with an ERA alone, a PDE5 alone, or the combination of an ERA and a PDE5 together from the beginning. And the results were exciting, and I think for a lot of us reinforced our belief that perhaps targeting at least 2 or more pathways in the treatment of PAH may be beneficial in our patients.
Yeah, very exciting. And then a new therapy with a novel mechanism of action. We have a little bit of data about Celexa.
So Celexa is an oral IP receptor agonist. It's not exactly a prostanoid, and it was studied as the trials of macitentan and the AMBITION trial in a long-term event-driven morbidity and mortality trial, the largest trial we've seen yet in pulmonary hypertension, over 1,100 patients, with the average drug exposure being over 2 years. So really a meaningful time being evaluated. And the top-line data has been presented, and it suggested that treatment with this agent, and 2/3 of the patients were on background therapy, but treatment with this agent compared to placebo reduced hospitalizations by about 40%. and that seems like a very significant and meaningful number. We're waiting for additional data from this trial. Hopefully it's going to be available in the short term, and both the European and United States regulatory agencies are reviewing data on the agent at this time.
Yeah, so really exciting times. It makes me think back to when I started doing PAH in 1995. It was really easy. You diagnose someone, there was one therapy, you know, there wasn't much of a conversation. Now we have a dozen, more than a dozen maybe, FDA-approved therapies. So that initial conversation is much more challenging. How do you now approach the newly diagnosed patient and talk to them about treatment options, and what's usually your go-to method for that?
So it's challenging, and part of the reason is that the drugs work differently and may be best in different circumstances. Patients' preferences would always be for a pill once a day as their first choice, a pill twice a day as their second choice, and going from there. But yet there are some patients where because of the progression of their disease or the advanced state at which we're first seeing them, where my bias would be that we need to use a parenteral prostanoid as first-line therapy. So it's a challenging discussion which involves an assessment of the patient's current status of their disease. Is it early in the disease or further along? Have they been on other therapies in the past? Are they progressing rapidly or progressing slowly? Are they showing signs of right heart failure? And it is much more challenging than when all we had was IV epoprostenol, and it was, is the patient sick enough to warrant this, and can they manage it? Right. You got 2 yeses, your decisions were done. Right,
so there are some, red flags that we want to get very aggressive with parenteral prostanoids, but let's talk about your typical functional class 2 patient, none of the red flags, they're appropriate for oral therapy. How do you start that conversation? What plays into your decisions there?
I think we have plenty of data with starting oral therapy and then perhaps adding a sequential add-on. But I think, as you mentioned, with the Ambition data, there's some emerging data that maybe we should even hit these younger, milder patients harder in the beginning. So I think it's really an evolving field. I totally agree with Harold. I think you have to tailor it to each patient. As a PH clinician, I really try to rely on evidence as much as possible. But at the end of the day, we also rely on our experiences as well. And you don't want to just square peg in a round hole kind of thing. Sometimes some patients, it's easier to start one therapy and then reassess.
I think it may be an oversimplified way of describing it, but perhaps you go back to, like I said at the beginning, in the 90s, there was just one treatment, and then we went through this long period where there was a lot of discussion about what was the one oral therapy we're going to use. And I find increasingly now when you're seeing newly diagnosed patients, what you pick that day to start on is important, but perhaps equally as important is that you're preparing people for the fact that they're unlikely to remain on one thing. I think we have enough data now, and we've seen enough progression in our patients to suggest that the majority are going to need 2 or perhaps more treatment. So I think that's part of the upfront conversation as well, especially in those who weren't expecting that.
And that's a key factor, is following the patients closely and reassessing that. How do you approach new patients, Paul?
Well, I think that as Harold suggested, there is some challenge because we don't have head-to-head data with these different agents, and we of course use risk stratification to select the intensity of therapy. But pertaining directly to your question about if a group of patients are of a similar degree of illness, and it would be reasonable to start any number of oral therapies, for example, then I think what you have to do is weigh the efficacy of the therapy in a population with the known side effect profile of a particular agent as it pertains to an individual patient. So, for example, if a patient has significant lower extremity edema and is of older age, then I may move away from an endothelium receptor antagonist as my initial choice of therapy because of fluid retention. Conversely, if a patient has scleroderma and they have severe esophageal reflux disease, I may shy away from a PDE5 or an SGC stimulator because it may aggravate the person's reflux. So it becomes a balance of the known effects and the known side effects.
Right, really great points. So has anyone adopted the upfront combination therapy strategy with an ERA and a PDE5 routinely in their practice yet?
I can't say that I have started doing it routinely just yet, but certainly the information preliminarily that we've seen is exciting. I think that, as you alluded to, Val, that whatever therapy we choose, if we are going to choose one therapy initially, but we're considering adding another, it's vital that we follow our patients closely to see if they're reaching their treatment goals and targets. Because what I don't know yet is whether if a patient should be started on 2 oral therapies up front, or if a patient could be started on a single therapy, followed closely and escalated in a short time frame, whether that is equally efficacious to upfront therapy together.
I think that's something we're all saying. You can't be complacent after starting therapy. Like Sean mentioned, you have to be very vigilant. And the days of just trying to improve their 6-minute walk delta by certain meters, I think those are gone. I think we have to make sure that clinically meaningful improvements are achieved. I think the REVEAL registry has taught us some poor prognostic signs as well on therapy. So I think the bar really has been raised. I mean, we want to improve RV function, so I think the endpoints are quite different now.
Right. So that's a great point. So how do we do that? How do we consider when's the right time to start combination therapy on that functional class 2 patient, maybe early 3 patient that we started on in oral therapy? When do you reassess them? What do you look for? How do you decide about adding another therapy?
So there's no one single thing, as we know. We don't have a hemoglobin A1C equivalent like our endocrine colleagues do for diabetes to say, listen, you're not controlled, you need to come back. You have a panel of things. So you're doing a lot of the mundane things. You're asking them how they're doing and putting them in a New York Heart or WHO functional class. And if you find that their capacity is slipping, that's always a worry. But that's sort of the easier one in a way. The question is, I think, what are you looking for before they symptomatically state they're worsened? So how much of a BNP rise do you tolerate? How much of an echo change is acceptable on a given day? And I think that's what we're still struggling with. So,
or even how much do they improve? I mean, the goal is to get them better, right? So if you start someone on a single therapy, what do you want to see before you say, gosh, we need something else? We haven't met that target.
And it's also what they want to see, because it's really very individual what patients' expectations from therapy are. I've had patients where I don't think we have improved things as we should, but they're happy being able to push the shopping cart around the store and play bridge a couple nights a week, and they're reluctant to consider another therapy. And I have other patients who've really had substantial improvements, and I'm really smiling at how good a job I've done, and they want more. And they have different expectations. And so that's an important factor, as well as all of the parameters we can measure, because we're trying to improve patients' functional status and their quality of life, and their expectations factor into that.
I think that's a great point, taking in the patient's perspective, the shared decision making. I think those are all really critical points. In terms of goals, I know, Paul, you probably look at things a lot the way I look at it as a cardiologist. I mean, we look at lots of data. I think, 6-minute hall walk, people are not relying as heavily on as much anymore, but it does play into the role. It's a good reflection of how patients feel. We assess a functional class, but just in terms of long-term outcomes, I think we rely a lot on how their RV looks.
That's right. And I think that we look at the World Symposia information from Nice, we're seeing that, corroborating what Nick was saying, that the bar is being raised. We are now talking about a goal being to either normalize or near normalize RV size and function. And this was really not on the radar screen 5 years ago. It was, improve the WHO functional class, improve the 6-minute walk distance, but not to really pay too much attention to what that right ventricle is doing. And if we are trying to achieve long-term, very good outcome, then many of us believe that a way to do that is to target our therapies to the point that the right ventricle is either normal or near normal. And if you do that, as long as the drugs are tolerated alone or in combination, that is likely going to be a way that you're most assured that the remainder of the targets and goals fall into place.
Yeah, I think it's critical. So we have a lot of new therapies. We have very different trial designs. I guess in this day and age, with so many patients going into trials on background therapy and now having a lot of long-term data from trials, what would it take for you to really believe in a new agent? What do you need to know about that if there was a new discovery for pulmonary hypertension? What do you want to see?
I like to see more and more that it applies to my clinical practice, that it's clinically meaningful. And I think things like reducing hospitalization, I think we're recognizing that's bad if patients get hospitalized regardless of what else is happening. You mentioned about RV function and whether it's echo, MR, or index over 2.5. I mean, these are things that we want to see a new drug achieve, I think, for me.
Do you think we've seen the last short-term 6-minute hall walk approved drug?
Yes, for drug approval, I think so, at least in PAH.
What do you guys think?
I hope.
I think there's certainly limits there, but I get a little concerned that another new entry, a new pathway perhaps that's tested here, shouldn't necessarily be subjected to a 3-4 year trial where the results are less certain there. So I'm not going to advocate that we keep 6-minute walk into place other than the secondary endpoint position, but I do think we need to look at some new entries. I mean, with RealCiguat, it was looked at as different because it had a different mechanism, and if we saw something even further outside of the 3 pathways we exploit now for treatment, I think either a shorter version of the event-driven, if we can find a robust enough endpoint, or using some other surrogates, perhaps the RV function measures Paul mentions, it's going to be important. So I think it's difficult. We'd like the kind of trials we just had published, but I don't know that this one trial size or design is going to fit all therapy approaches as they evolve.
I think those are good points. We don't want to discourage development of novel compounds because that bar is set so high, but we do want the bar set high for our patients. So maybe at some point there'll be some sort of a happy medium, a longer time to clinical worsening type of trial, or a 6-minute hall walk with a follow-on type of trial. But with all the new discoveries we have in 2014, 2015, is that treatment, that beautiful little algorithm that we made in Nice, is that outdated? How does that need to be revised?
It's an evolving algorithm. I think we've seen that over the other World Symposia and other publications as well. So I think that's a good thing for the field, that it's constantly being evolved, because it means we're really pushing the envelope and coming up with better ways to treat. So I'm sure it'll get revised. It's going to be a difficult task, though, given how full the armamentarium is.
I feel like the algorithm, to a certain extent, there are things in that algorithm that we now absolutely know are true as experts in the disease. And then there are other things that we put into the algorithm that we believe to be true, that we know are in the process of being proven or disproven. So with each rewrite of the guidelines, things that may have been less than perfectly clear, but we thought we're on the right track, sometimes those things get a bit more emboldened as our evidence builds, and then it becomes kind of more fastened and believable on our next rewrite, and we continue to learn.
I think one example is the combination algorithm, right? Because
right.
They kind of lumped it into a high-grade recommendation, whereas I think we're recognizing not all combinations and all scenarios actually work. So that may need to get fleshed out a little more detailed.
Yeah.
But the key point is that whenever we make a decision about a therapy for a patient, be it a single drug, be it a combination, be it parenteral therapy, whatever we do, that it needs ongoing reassessment to make sure that we're actually benefiting our patients and achieving the goals that they and we have set, and that we actually clearly still have a pressing need for new therapies because we have evidence that the drugs we use, even when they're successful, Stu Rich's long-term patient on IV prostacyclin, who died of another cause, and the lung looked awful at the autopsy.
But the right heart looks good.
Right. So we still need to come up with agents that are going to work on remodeling the pulmonary vasculature, changing the fundamental process within the lungs, because that'll help the heart.
Right. Well, I think I can sum that up as we've made a lot of progress, but we haven't crossed the goal line yet, so there's still work to do.
Yeah.
So a really exciting time in pulmonary hypertension, novel agents, novel trials. It was really fun to talk about all of that with you guys. Thanks so much, and thank you for joining us.